Yes, good evening all and welcome to the recall session of Pharmacology, INI-CET May 2022. Myself, Dr. Bharath VD. I am the Pharmacology faculty, DBMCI and eGurukul. So let me check whether the audio video is fine. Everything is fine, then we can proceed. So we'll start this. What is the purpose of this video is to analyze the questions and answers, and all these are recall based questions. Second, why we should know this, because these questions may appear in your NEET PG 2022 exams also, which I will be on May. And along with that, we need to understand, suppose in the future exams, the same concept comes, what are the things we need to understand in these cases. So let us start. Just a minute, I will confirm audio video is fine. Yeah, so everything is fine. Let us start with the first question. And yeah, some initial issues. Yeah, it's okay. We'll come back to that. So let us start with the first question. Patient on risperidone comes to emergency room with upward fixed gauge. How do you manage this? Now, patient has come after taking risperidone. What is risperidone? We all know that risperidone is a atypical antipsychotic. Atypical antipsychotic. What do you mean by atypical antipsychotic? It's a drug which blocks mainly IST2 and lesser D2 blockade. But risperidone has a specialty. The drug, if you use it more than 6 milligram per day, that is a higher dose, it can also block D2 receptor. And we have discussed that in our classes. When we use risperidone at higher doses can cause D2 blockade, and it can cause extrapyramidal symptom. So now what is the immediate extrapyramidal symptom that occurs is, one is called acute dystonia and one more is oculogyric crisis. I'll show that image of oculogyric crisis. See, this is what the meaning of that. This is another image where you can see the fixed gauge. This is the oculogyric crisis. Why this occurs is when we give a D2 blocker, the acetylcholine level decreases. The activity of the dopamine decreases and the activity of acetylcholine increases. This is the reason why this acute dystonia and oculogyric crisis occurs. So what should I do? I have to treat it with central anticholinergics. For example, the central anticholinergics what we use is the benzhexol, then bipyridine and benztropine. So benzhexol can be used. Suppose benzhexol is not available, then we can also use promethazine. Analyzing this question, when the risperidone was given, patient had upward fixed gauge, that is oculogyric crisis, and the treatment for this is injection promethazine. Now, why do we use promethazine? Because it's an antihistamine having high anticholinergic property. That is why we prefer this. The question is this a repeated question? Yes. Remember, risperidone is a favorite for examiner. Every time it has come. Last 2 years back, NEET PG, they had asked which drugs can increase prolactin level. Risperidone was there. Not only that, any drug which blocks D2 in the brain can end up with EPS, and they are nothing but typical antipsychotics like haloperidol, droperidol, chlorpromazine. They can also cause this. But usually atypical will cause it lesser. The risperidone is an exception where higher dose can cause this. Can you tell me an antiemetic which can cause this extrapyramidal symptom? That is another important thing they ask in exam. I'm waiting for your answers. What is that antiemetic which can cause the extrapyramidal symptom? So for this question, the answer is promethazine, a repeatedly asked concept in your exams. So this is the oculogyric crisis. Now the next thing is the catalase peroxidase mutation occurs in where? Now we have discussed the mechanism of isoniazid. Isoniazid is a prodrug and it has to become active. To make it active, what we require is an enzyme called catalase peroxidase. This enzyme is coded by the gene called CATG gene. Now, if this CATG gene becomes mutated, then the catalase peroxidase is not synthesized properly, so the INH will not become active. So that is a major mechanism of resistance where catalase peroxidase will not work. Another important INH mutation is because of INHA overexpression, and one more is mutation of CAS-A gene. So these two genes are also responsible for the mutations. Yes, you are right. The drug antiemetic which causes extrapyramidal symptom is a D2 blocker, metoclopramide, because it crosses blood-brain barrier. Every time they have asked that drug, metoclopramide. Now the answer for this is isoniazid, and it is because of the CATG gene mutation. Rifampicin is because of RPOB gene. Pyrazinamide is because of PNCA gene, and ethambutol is because of mutation of MB gene. So here the answer is isoniazid. Can you tell me whether this was the exact question asked? Okay, that is isoniazid. So cyclophosphamide active form is. Now many a times these type of questions are taken directly from the Goodman and Gilman, and we have studied in the classes cyclophosphamide is a prodrug. We all know that cyclophosphamide is a prodrug. Now this cyclophosphamide is converted into aldophosphamide. Aldophosphamide. And from this aldophosphamide we get two things. One is called phosphoramide mustard, and one more, and that is called acrolein. Now this phosphoramide mustard is the one which causes anti-cancer effect. It is the one which is active, it will produce the anti-cancer effect. Acrolein is responsible for causing a complication called hemorrhagic cystitis. So when we see this, nowhere it is shown the options. Whatever you see, N-methyl, N-acetyl, 4-hydroxy or 4-ketoacyl, nowhere we are seeing the option here. Now this is an image taken from Goodman and Gilman. Actually what happens is cyclophosphamide is converted to active compound that is called 4-hydroxy cyclophosphamide. 4-hydroxy cyclophosphamide. And now this is a isomer. It is called as tautomers. These are called tautomers. That means both are structurally same. Only the position of groups will be different. So 4-hydroxy cyclophosphamide will give us to aldophosphamide, and then you will get these things. So this particular step they have taken from Goodman and Gilman, and they have asked in your exams. So it's a factual based question. So coming to the answer, it is C. It is called 4-hydroxy cyclophosphamide. That is the active form of this drug, cyclophosphamide. And where do you use cyclophosphamide? It's a drug of choice for vaginal granulomatosis. We also use it in non-Hodgkin's lymphoma. It's an anti-cancer drug. Yes, image was given. Okay. Yeah, for INH, image was given. It's okay. Now, how do you combat this hemorrhagic cystitis? We use a drug called Mesna. And cyclophosphamide can also generate chlorostaldehyde in a minor quantity, but a congener of this ifosfamide generate chlorostaldehyde, which is highly neurotoxic. Yes, the answer is C for this. This is what I got the answer question from most of the students. Mark the different curves. So the question I don't got the full question. So remember, a full agonist is the one which produces +1 response, that is 100% of response, that is +1. Partial agonist is the one which produces a response between 0 to 1, not 1, not 0, between that. Antagonist was the one which produces zero response. And one which produces the opposite effect, that is -1, that is called inverse agonist. So we have discussed that when we discussed particularly the benzodiazepines. So for benzodiazepine receptor, the agonist is the benzodiazepine like diazepam and Z-drugs. The antagonist for this benzodiazepine receptor is flumazenil. And the inverse agonist for this is called beta-carbolin. Suppose benzodiazepine causes sedation. The inverse agonist beta-carbolin will cause excitation, so patient may have seizures. So we have discussed this. So the answer for this question is, whatever they have given, this is the fact. We will understand the fact. What is the, if they ask in the future exam, this is the image. So if you can recollect, just message me guys, so it will be easier. Now let me move on to the next question. It's a general pharmacology question. It will come in physiology and pharmacology also. So phospholipase acts through, what is that? GS is a receptor which will stimulate adenyl cyclase, which will convert ATP into cyclic AMP. So it will increase cyclic AMP. GI decreases cyclic AMP. What does GO do? It inhibits calcium channel. That is GO. What does GQ will do? GQ will activate the enzyme phospholipase, and that will split PIP2 into IP3 and DAG. So the answer for this question is B. Phospholipase, it acts through GQ coupled receptor. Now we have discussed this in our classes. What acts on GI means decrease in cyclic AMP. GQ means activates phospholipase C, which will cut the PIP2 into IP3 and DAG. Let us move to the next question. ACTH. ACTH is used in, usually ACTH, we know that it is for infantile spasm. Now it is used in West syndrome. Suppose the patient is having infantile spasm plus tuberous sclerosis, then what is the drug of choice? Anybody? What is the drug of choice? Lennox-Gastaut syndrome, the drug what we use is valproate. Juvenile myoclonic epilepsy, also the drug what is preferred as the first line is valproate. Even for generalized tonic-clonic seizure, it is valproate. But remember, one update I want to give you is about absence seizure. Absence seizure, the drug what we use is valproate. If they have not given anything, then valproate is the first choice. Suppose if they give childhood, any age, childhood age, and absence seizure, then as per the update, now it is ethosuximide. So the less than 2 years, less than 4 years, like that, notice there. If it is a child, then it is ethosuximide. This is the one. Yes, very good. If a patient is having infantile spasm with tuberous sclerosis, the preferred drug is vigabatrin. But what is the drawback of vigabatrin? Remember, it can cause vision impairment. And that's why it's very difficult to give it in children, because they cannot tell that vision impairments. That is ACTH used in. So we have discussed this in our classes. What is the treatment for GTACS, myoclonic, and then the febrile seizures, focal seizures, and all these things we have discussed in that. Now, another I got as a question is, following image is showing mechanism of which drug? So there, the students told me that the image was showing mycolic acid. The mycolic acid synthesis is inhibited by isoniazid. So isoniazid inhibits mycolic acid synthesis, and this is required for the cell wall of tuberculosis. Ethamotol inhibits same cell wall, but it inhibits arabinogalactan synthesis. Arabinogalactan synthesis, which is also a part of cell wall. So pyrazinamide also inhibits cell wall synthesis. So all the three drugs inhibit cell wall synthesis, but streptomycin inhibits protein synthesis in the bacterium. protein synthesis in the bacteria. Now, can you tell me which first-line drug in tuberculosis can decrease RNA synthesis? Which first-line drug in tuberculosis can decrease RNA synthesis? I'm waiting for your answers. Yes, so we have discussed the same thing. INH, active form. Penultimately, what does it do? It will inhibit mycolic acid synthesis. The cell wall is not formed properly, and it is a tuberculocidal drug. And I told you the mutations are because of two important genes, that is the CAT-G, INHA, and one more is Cas gene. Apart from that, till now what I have noticed is, remember this isoniazid can also inhibit DNA synthesis, right? It also inhibits DNA synthesis. That is one thing they have not asked till now. Sir, in pregnant with epilepsy, levetiracetam or lamotrigine, among them which is preferred? Preferred one is levetiracetam. If they are given both of the options, levetiracetam will be the better one. Monica. Yes, so we understood that. Now let us move to the next question. 42-year-old man with the raised AST, ALT, GGT. It is raised, showing altered sensorium and seizure. Drug to stabilize the patient. So patient is having seizure. Then which one is better? Lorazepam, diazepam, alprazolam, or clonazepam? Now remember, there are certain drugs which are benzodiazepine, which are safe in liver disease. So patient is having liver disease, or a patient is a chronic alcoholic. In them, the best ones are lorazepam, oxazepam, and one more is temazepam. So these are the safest to use in a patient having liver disease or a alcoholic, chronic alcoholic patient. So here the answer would be A, lorazepam is the one. Some books will also give triazolam, estazolam, but exactly if you want, these are the three drugs which are safe in liver disease. Why? Because they will not produce an active metabolite. If I take diazepam example, metabolite will give rise to non-diazepam, and from that we get oxazepam. So the problem when I give it in liver disease patient, diazepam will become very slowly non-diazepam, that is also active. Non-diazepam will become oxazepam, that is also active. So he will have longer action of the drug. So these drugs will undergo direct glucuronide conjugation and they produce inactive metabolites. That's why they are safe in liver disease. It is again a repeatedly asked question we have discussed in the classes. These are the ones which are safe in liver disease or alcoholic patients. Yes. Now moving on to the next important question, extent of drug absorption. I don't know whether it was extent or extent of drug absorption. Just a minute. Yeah. So we got the question, extent of drug absorption from the graph can be known by which of the following? It's a repeatedly asked question. It has, the concept is already asked. Last exam they had asked area under curve. What parameters will increase the area under curve? Before that exam they had asked what will tell us rate of drug absorption. So the concept keep on repeating, so you have to concentrate on this topic. Remember, extent of drug absorption is given by the area under curve. Now the area under curve is used to calculate bioavailability. It is used to calculate bioavailability. Now how do you calculate bioavailability? It is given by area under curve, oral or any route, not only oral, any route, divided by area under curve IV into 100. So this is the formula to calculate bioavailability of a drug using area under curve. So if I want to tell you this bioavailability graph, remember this is the bioavailability graph where we plot time in x-axis, drug concentration in y-axis. We get a curve like this. Now why the curve is going up? It is because of absorption. The concentration where it is maximum is called Cmax. The time where it is maximum is called Tmax. So Tmax will tell us rate of drug absorption. And area under curve will tell us the extent of drug absorption, and also it will tell us how much is the exposure of the drug by the patient. How much is the exposure of the drug by the patient. So these are the two parameters. Particularly I had highlighted to you during classes. Remember rate of drug absorption and extent. Which route has fast rate of absorption? Yes. Can you tell me that? I will be waiting for your answers. Now another easy one, match the correct option. Number one, hydralazine, heart failure. Hydralazine, remember, it's a mainly arteriodilator. Main thing they can ask you about this is it can produce drug-induced lupus. Hydralazine can produce drug-induced lupus. Apart from that, not major adverse effect is asked by that. Now, will it cause heart failure? No. It is used in the treatment of heart failure along with isosorbate dinitrate plus hydralazine. These are used to decrease mortality in particularly African-American population, not in our country. And can you tell me one more drug which can produce drug-induced lupus, which is an antiarrhythmic? It is called procainamide. These are the two drugs implicated in causing drug-induced lupus. Atenolol. Atenolol will not cause hemolytic anemia. Atenolol is a beta blocker. Any beta blocker, the problem is they can decrease exercise capacity. Not only that, they can increase potassium, hyperkalemia. Beta blockers, remember, they cause hyperkalemia, but beta 2 agonist, they can cause hypokalemia. Verapamil, yes, obviously, it's a calcium channel blocker. It causes constipation. This is the drug which can produce that. Verapamil can produce constipation. Not only that, the calcium channel blockers can cause vasodilation. They can decrease the blood pressure. Along with that, they can cause headache, flushing, constipation, and only the DHPs, dihydroproteins like dipins, they can cause reflux tachycardia. Verapamil will not cause reflux tachycardia. But characteristic of CCBs which they can ask you in the exam is, one is the gum hyperplasia. CCBs means, remember, they can ask you an image-based question, that is gum hyperplasia. Can you tell me two more drugs which can cause gum hyperplasia? I am waiting for answers. Allosterone is a renin inhibitor and it will increase potassium. So remember, anything which affects the RAS pathway, either it is a beta blocker, renin inhibitor, AC, ARB, spironolactone, all of them are going to increase the potassium. Question, one more drug which can produce gum hyperplasia is phenytoin. So phenytoin is a drug which can cause gum hyperplasia. Just a minute. Yes. Now remember, cyclosporin, phenytoin can cause gum hyperplasia. I'll give a clue. Phenytoin and cyclosporin. And remember, phenytoin and cyclosporin, they can also produce hirsutism. Right. So that is the match the following. The right match is this one. And we have discussed the adverse effect of DHPs in our classes. And it is particularly mentioned constipation. Yes, even the nitrates can cause constipation in this case. Now this is one more question, I got it. Please tell me whether this was there in the exam. Patient was on tamoxifen after a breast cancer surgery. For around 5 years, she was on tamoxifen. When she should stop tamoxifen if she wants to conceive? So take your option and tell me. 1 month before, no need to stop. Just stop and conceive, must continue even after pregnancy. What is the best answer? Even if you don't know anything, I think you can get. Now remember the guidelines for tamoxifen. You know that tamoxifen is an anti-cancer drug. Now the point is, whenever we give an anti-cancer drug, there is a risk of teratogenicity. So we don't want to take a risk. That is why whenever we prescribe tamoxifen, we tell the partners to use condom, that is barrier methods. So even after stopping that barrier drug, we tell them to use it for 3 months. Means she should not become pregnant for 3 months. So minimum duration to conceive after stopping tamoxifen is 3 months. Right? So if they have given 3 months, that is the best answer. I have got 1 month only in the recall based. If they have given 3 months, please remember that is the best answer. It has to be stopped 3 months before conceiving. Yeah. If it is 3 months, yes, that is the right answer. No need to stop. No, you have to stop only because it's an anti-cancer drug. Just stop and conceive because the effect of drug will be still there. If you continue during pregnancy, yes, it's a teratogenic drug. So if you are given 3 months, that will be the right answer. Yeah, we are clear with that. Now moving on to it's again a simple question. N-acetyl parabenzoquinonamine, and many of them told that it is given as NABQI or it is given as NABQI. You have to tell me how it was given. Causes hepatonecrosis due to what? Yes, it is obviously the drug paracetamol. And we discussed that a lot of times. Paracetamol is metabolized by the enzyme cytochrome 2E1 into NABQI, and it is metabolized into mercaptouric acid, and it is going to be excreted through urine, and here we require glutathione. So what happens in paracetamol toxicity? Higher doses, the generation of NABQI increases, and that is going to cause hepatotoxicity. And if there is a risk of hepatotoxicity higher dose, we need to replenish glutathione store, and what we use is N-acetylcysteine. We have repeatedly asked this. So if they have given full form, very good, Jyoti, then it will be an easy question to you, and the answer would be paracetamol. There is no confusion in that. It's a direct question. Yes, we have discussed this metabolism. You can see paracetamol, phase 1, NABQI, mercaptouric acid, hepatotoxic. We have discussed that. Now, another important controversial is which antidiabetic drug causes osteoporosis in a woman. And if you see into this, okay, full form was there, epidemic dropsy was there. Okay. So in that epidemic dropsy was there. Let me write that option for you. But that is not the answer, but let me take the option. Now there are two drugs to belong to thiazolidinones. These two belongs to thiazolidinone. These two belong to thiazolidinones. Now I am quoting from Goodman and Gilman. According to Goodman and Gilman, 13th edition, he has mentioned that both rosiglitazone and pioglitazone can increase the risk of fractures in female. And also it is shown in male, but more commonly it is shown in female. If the examiner had taken the question from Goodman and Gilman directly, that means he is asking a question from this one. So the answer would be rosiglitazone. But canagliflozin belongs to SGLT2 inhibitors. The SGLT2 inhibitors, now the FDA has given a warning that they can also cause increased risk of fractures. So if they are taking the recent update, then this would be the answer. But in the canagliflozin case, they are not mentioned in women. So particularly if they are asking in the female, as per my opinion, the answer would be rosiglitazone from the standard textbook Goodman and Gilman, because majority of the questions which are being set, because these are from JIPMER, because JIPMER now comes to INI-CET, they will take from Goodman and Gilman and ask. If they have asked from that angle, if a female is given, yeah, I know that many are telling canagliflozin also. I too have studied about that, but I am giving you what is there in the textbook. So Goodman and Gilman 13th edition, it is giving that both rosi and pioglitazone can increase the risk of fractures, particularly in female, and the risk of osteoporosis, if they have taken from that. Otherwise, if they have read the FDA warning and given this, then it will be the answer, canagliflozin. Now, why rosiglitazone is opposed by many? Because rosiglitazone is not used nowadays. But we don't know the examiner what he is going to ask. So I have given you the fact. Okay. And that is what Kaustup, that's the problem. After the exam, if they give us the answer and the reference, then nobody will have a confusion. So is it asked osteoporosis in women, then it will go for rosiglitazone. As per my opinion, it may change also, but this is the fact. No, Satya Prasad, it doesn't mean that I'm always correct. I am giving my opinion. Right. So considering these facts, it's not only in women. So cannabis can be ruled out, but I can take rosiglitazone as the answer right now. Yeah. Now we have discussed this in our class also. I have told you thiazolidines can cause weight gain, water retention, increased risk of bladder cancer, increased risk of fracture in females. We have written that particularly, and I have referred from Goodman and Gilman only, and I have given this. And very rarely macular edema can occur. Now, moving on to the next one. Female came to psychiatric OPD with symptoms of hypomania, past history of hypomania. She is now planning to conceive. Which drug should be avoided? Now, here we have two drugs which are trying to confuse us, lithium and valproate. Now, this is not going to confuse us. Why? Because if you are trying to attempt this INI-CET, that means they want you to study some journals. Now, as per a journal which has recently come, it is telling you that in management of acute mania or mixed episodes, they have done a study, lithium and valproate. Now, both of them belong to category D drug, that is, they can be teratogenic also. But if you see lithium, the overall percentage of major congenital anomalies, MCM means major congenital anomalies, is only 2.8%. But if I consider the risk with valproate, let us see valproate, the risk of major congenital anomalies is 5 to 11%, that is highest. The risk is highest with this one. And also it has increased risk when you combine with other anticonvulsants. It also produces the neural tube defect and neonatal toxicity. Most teratogenic will be valproate, and this is taken from a study. Because what they do in INI-CET, they will have this discussion of journals, there they will come to this point and the same questions will be posted in the exam sections. What about carbamazepine? Yes, carbamazepine also has shown to risk of 2 to 6%. Even that is used in bipolar disorder and mania. It is also having that. Yeah, happiness. The problem is that one. Now, what about the atypical ones, clozapine, risperidone? They are MCM, that is, congenital abnormalities are not so much, they are unclear. So that's why atypical antipsychotics, clozapine, risperidone, they are the safest to be used in bipolar disorder. Only one typical antipsychotic, chlorpromazine, can be used in pregnancy. Otherwise, a pregnant woman with mania and bipolar disorder, the safest ones are atypical antipsychotics, atypical ones. But if you want to avoid between lithium and valproate, so what you can exclude is lithium, because the congenital anomalies are lesser compared to valproate. So that's why this is the best option among this. Okay. Yes, most teratogenic. Yes, you know that. Dr. Acres, yeah. See, remember, rosiglitazone may be withdrawn from our India, but is still used in some parts of US, but is still used in other countries. So there they have found out it has the risk of fracture. Yes. Now, let me move on to the next question, which is not a primary treatment agent in rheumatoid arthritis. Remember, it's a simple, straightforward question. Methotrexate, obviously we use it. Hydroxychloroquine, we use it. Sulfasalazine and leflunomide. These are the DMARDs which we start in the rheumatoid arthritis. First, we'll attempt with the methotrexate. Otherwise, we add hydroxychloroquine, sulfasalazine, leflunomide, depending on the response. Or along with that, we use biological agents like TNF alpha blockers, like infliximab, adalimumab, etanercept, or nowadays the JAK inhibitors are there. What are the JAK inhibitors? One is called tofacitinib. They have asked this already. And baricitinib. These are JAK inhibitors. So they can also be started in this patient because the JAK inhibitors are oral, so they can be given. TNF alpha, they can be given injections. So the one as the first agent. Not only azathioprine, the cyclophosphamide, cyclosporin, Those are the one which are not asked first line. Now please remember one important drug, UPA dasatinib, or you can write it as UPAS dasatinib. This is not being asked till today in the exams. So any of the NEET PG is approaching, this is a JAK inhibitor which is used for treating rheumatoid arthritis as well as ulcerative colitis. This is not asked. So any new drug coming to the rheumatoid arthritis, the examiner will ask. So this is not asked till now. Last exam also they had asked tocilizumab, it's an interleukin 6 antagonist. Sarilumab was asked, interleukin 6 antagonist. Tofacitinib is asked, baricitinib is asked. What is left out? This one. Please note down this. Yeah. So let me move on to the next question. Another easy question. So just a minute. Again, the background is not seen. Yes, so a direct question, 5-alpha reductase inhibitor is given to. 5-alpha reductase inhibitor, what is the role of 5-alpha reductase is to convert testosterone to dihydrotestosterone. So to convert testosterone to dihydrotestosterone, the enzyme is called 5-alpha reductase. Now this dihydrotestosterone is responsible for causing androgenic alopecia, benign prostate hyperplasia, and hirsutism in females. So if I want to treat this, I need to inhibit this enzyme. The drug which inhibit that is finasteride and dutasteride. So if I inhibit this 5-alpha reductase, I am going to decrease dihydrotestosterone. The answer is D, decrease intracellular dihydrotestosterone. And in that, only finasteride is approved for all the conditions. Finasteride is approved for all these conditions, but dutasteride is only approved for BPH only. And remember, they both can decrease the prostate size, and they take time, but they will decrease the prostate size. Okay. This was multiple correct option. What was that? Yeah. Now we have discussed this in our classes. 5-alpha reductase, when inhibit, dihydrotestosterone decreases, and we use it in these conditions. Okay. Yeah. Yes. Now another important aspect. And it's important why we need to know this. A sample of paracetamol labeled as 500 milligram on identification by the government authority found that this drug contains only 200 milligram of paracetamol. According to the Drugs and Cosmetic Act 1940, what is the term used for? Misbranded, spurious, unethical, unadulterated drug. Now there is nothing unethical drug. We'll rule out that. But what is misbranded drug? Now remember, misbranded drug means, I will show you, this is what we mean by a drug label. So drug label will contain all the name of the drug, storage conditions, direction for use, the drug schedules, the expiry date, all these are mentioned in the label. Suppose in the labeling, if they make a mistake, then they are called misbranded drug. If the labeling is a problem, we call it as misbranded. I'll take an example. You know that this is Calpol 650, tablet Calpol 650. In this case, what happens? On the label, they have mentioned 650, but when you see the tablet, inside the tablet is Calpol 500. By mistake only, they have put Calpol 500 mg. So this is, instead of putting Calpol 500, they have put Calpol 650 by mistake. And this is called misbranded drug. Simply remember, the problem is in labeling. They may have missed the expiry date only, they have missed the manufacturer name, they have missed the drug schedule. So all this comes under misbranded. So as per the question, it is misbranded, but let us not stop here. It's a repeatedly asked question. It's not the same question. It has been already asked in your exam. What is spurious drug? Spurious drug, I think why this question came, because during second wave, we had to face the spurious drug. Suppose a drug company called Hetero, they produce a remdesivir. A fake company started synthesizing the same drug with the same brand name, same drug name, everything is same. So it's like a duplicate, but it will not work. So the spurious drug means it may not have the active ingredient. Instead of remdesivir, they have put some normal saline. Or instead of remdesivir, they would have taken half remdesivir, half of normal saline. Or they would have changed the content only. Or they want to mimic the company. For example, you want to give this is the standard one. And I'm a poor company, I want to make money. I will get one more similar looking, same package, same thing. Instead also same thing. That is called spurious drug. The third one is adulterated drug. What is adulterated drugs? For example, in the drug we find poisons, toxic substances. It is adulterated with something else. That is called adulterated drug. Now, Dr. Akres, counterfeit drug, we don't use that terminology in Drugs and Cosmetic Act. Counterfeit and all, they come under spurious only. Counterfeit means you are giving a fake one, that's it. Now, as per Drugs and Cosmetic Act, only we have three terminologies. One is misbranded, that is a labeling error. Second one is spurious. Counterfeit is what we are saying, and that is not in our Drugs and Cosmetic Act. What we tell is spurious drugs. So counterfeit also comes under that. Yes, you are right. Happiness zone. Break powder in chili. Okay. So we got this point. Okay, let's move on to the next one. Magnesium sulfate. Was this question asked? Now, magnesium sulfate is a beautiful drug of the century. Why? If I give it in GIT, it acts as it causes diarrhea. If I apply on a wound, it causes wound healing. It decreases inflammation. You know that magnesium sulfate does sing. But the same magnesium can also cause uterine relaxation. Not only uterine relaxation, it's a bronchodilator. It can cause bronchodilation. So extremely sorry, the screen is not coming back. Again and again there is an issue. Just a minute. Yeah, so many have answered that. It controls seizures and provides neuroprotection. Was there in option? Let me write that. Yes, it can provide neuroprotection. But let me see the other options. Loading dose can be given in renal failure. Maintenance dose should be adjusted on renal function. Yes, see, loading dose, I have told you in pharmacology, pharmacokinetics, loading dose depends on volume of distribution. Maintenance dose depends on clearance. So clearance depends on kidney. So maintenance loading dose you can give in renal failure, but when you are giving maintenance dose, you have to monitor the kidney function test. Now that's why whenever we give magnesium sulfate, we will be monitor the respiratory rate, the deep tendon reflux, and urine output. So if they are decreasing, then magnesium toxicity should be suspected. Now I will ask you, what is the antidote for magnesium toxicity? What is the antidote? Anybody? Magnesium sulfate is a uterine relaxant, very good. It's a very uterine relaxant, that's why we can use it in eclampsia. Suppose it's an uterine stimulant, that means whenever the lady has eclampsia and I give magnesium sulfate, she will deliver your labor pain. So it's a uterine relaxant. Magnesium sulfate can cover seizure and hypertension. No, it will not cover the hypertension. It will cover seizures but not hypertension. It is FDA approved for preterm labor. Can we use it for preterm labor? No. Even though it is a uterine relaxant, it is not approved by FDA for managing preterm labor. It's a uterine relaxant. My question is, yes, very good. The antidote is calcium gluconate. So whenever we solve this type of question, my purpose is not to tell you the right answer. I will tell you that. But purpose is to, from these questions, what other questions I can frame. Now magnesium sulfate, can I use it in status asthmaticus? Can I use it in status asthmaticus? You tell me. Yes or no? I am expecting your answers. Come on. Yes, you can use it because it's a bronchodilator, and we can use it by which route? Nebulization, as well as we can use it by intravenous route. Magnesium can be used. So this is about magnesium sulfate and how do we monitor. Now coming to the half-life of letrozole. The half-life of letrozole, usually they should not ask this, but why these type of questions come? These type of questions come so that they can make the paper tough and can give the rank. Suppose if you know all the 200 questions, then how can I give a rank for it? And these are a guess type of question. So it all depends on whether you should attempt or not. Cricket match doesn't mean that you will hit all the balls, right? You will be defending some ball, some you will be leaving like that. These questions like that, it will be a bouncer. If you try to hook it up, you will be caught. So better if you know the answer, you answer it, otherwise leave it. Now letrozole, the plasma half-life is around 40 hours. Even if you take it from Goodman and Gilman, if you take it from A.D. Tripathi, it is given like that. So the approximate answer is 45 hours. But every drug has one more half-life that is called elimination half-life. There is a time required by the drug to go out from the body. To go out from the body, not from plasma. It is given as 5 to 7 days. Even if I take this half-life, 5 into 24, it will be more than 120 hours. So the right option will be 45 hours. Right. So this is as per the Goodman and Gilman. Now, which drug is not given in sickle cell disease? Which drug is not given? You know that we use hydroxyurea, but we don't know other options. And I want you to ask whether these are the options we had, any other option was changed. Now, there were certain new drugs approved for the sickle cell disease. I'll show you that. One is called crisanilizumab and L-glutamine. Now, they are known to decrease vaso-occlusive episodes in sickle cell disease. Then, one more drug is oxalotar. Now, oxalotar is going to decrease the hemolysis, and it is also going to increase the hemoglobin levels in case of sickle disease. So these are the 3 drugs. They have been used newly for sickle cell disease, and it is from a journal. They have taken directly from that. The image is also from that journal. So crinzalizumab, L-glutamine. Why L-glutamine? Because it decreases the oxidative stress and stops the sickling. What about crinolizumab? Crinolizumab will block a P-selectin in the endothelium. So if this P-selectin is active, it will allow the aggregation to occur, and that will cause vaso-occlusive disorder. So crinolizumab inhibits P-selectin. See, please understand the question. Problem is they have to give the rank. They will ask this type of tough questions. Even for everyone, it will be difficult. But point is, again, if they ask you NEET PG 2022, we should not be making the mistake, and we should be writing the right answers. That's the purpose of this video. So let us learn that. Now, in all these options, what we have discussed, hydroxyurea is used, oxalotar is used. Now, remember this bebtelovimab is a one which is against spike protein, and that is used in COVID-19. And where? In mild to moderate disease of COVID-19. So this is the one which is not used in sickle cell disease. Yes. Now moving on to the next one. Which of the following is not immune checkpoint inhibitor? Now please tell me whether the options were same or is it any difference? Is there any differences in the option? Cetuximab, ipilimumab, pembrolizumab, atezolizumab. Now, even if you don't know anything, if you know that cetuximab is a epidermal growth factor receptor antagonist. So it blocks this epidermal growth factor. We have discussed that in the class also. And it is used to treat colorectal cancer. And also it is used to treat non-small cell lung cancer. But why the question about immune checkpoint inhibitor is asked now? Why the question comes? The question comes because in 2018, the Nobel Prize was given for medicine for the discovery of telling a fact that the cancer cells escape immunity. So our immune cells will not kill the cancer. Just a minute. So this is an antigen presenting cell and this is a T cell. Now you want to activate the immunity. So there is a receptor called T cell receptor and we have CD3 here. Another important one is we have CD80/86, which is called co-stimulant. It will activate CD25. So if they bind, then only you will see the immune response. That means we call it as acceleration of immunity. Now why this should be stopped? Because many a times our own tissues can be considered as foreign. We have seen in autoimmune disorders. So that is called break. Now how will the T cell recognize that the antigens are our own? There is a mechanism, that is the CD80/86 will bind with a target called CT. It is called CTLA4. So if CD80/86 bind to CTLA4, then the immunity will stop. That is called break. Will break the immunity. So that means the antigen is ours. Don't mount an immune response. Same thing is done by one more, that is the program death ligand 1, and this will express PD1, and if they attach each other, again the break is applied. The cancer cells are not killed, or the antigens which are our own will not kill. Then the scientists thought, if I want to kill the cancer cell, what happens when the cancer cell die? They will produce an antigen, and the antigen is given to the antigen presenting cell. Then the immunity should remount, but it will not happen because the PDL1, PD1, the CTL4, they are going to inhibit the immunity, so cancer cells are not killed. Then they thought, why don't we block this? So that is why we discovered the drug which blocks program death ligand 1, and that is called atezolizumab. And the one which blocks PD1, they are called pembrolizumab. Right. So now this is the trending in cancer therapy, and they got Nobel Prize for discovering this. And obviously, when a national institute, an institute of national importance are giving an exam, they will ask you this concept. Why? It's a pathology and pharmacology based question. And you don't want us to become a Nobel Prize winner. Yes, we doctors are also researchers, and they want to ask these type of questions for that. Now we can also block CTLA4, and if we come back to the question, now this ipilimumab is the one which inhibits CTLA4 and it blocks that break, and then the immunity will get responded. And this is against PD1, and this is against program death ligand 1. So these are all now the trend. This is the trend, and they are used in so many cancers. Particularly ipilimumab is used in the treatment of melanoma. Now let us move on to this. We have understood that concept. What is the drug used for treatment of advanced endometrial cancer? Now is it easy to answer? Now we can rule out trastuzumab because trastuzumab is used in breast cancer. What about pembrolizumab and nivolumab? Now nivolumab is also a blocker of PD1. Pembrolizumab is also a blocker of PD1. Right. Now, how will I know it's the use of endometrial cancer? It's again a toughest question to answer, because I'll show you the use of pembrolizumab. You just see that. What are the uses of pembrolizumab? I told you the discovery has led to the treatment use of this drug in so many cancers. You see the use of pembrolizumab? You can pause the video and see. So in that, one of the uses is endometrial cancer. As a student, I don't think it will be easier to remember so many things, because you don't have pharma only, you have other subject to read. So in the previous exam, they had asked about the use of nivolumab. You can see this. These are the uses of nivolumab, and they had asked a question: where is nivolumab used in the previous exam? Hodgkin lymphoma. There are 8 uses for this, and 18 uses for pembrolizumab. Why the uses are increasing? Because they are immune check inhibitors. Now these type of questions are usually asked by INI-CET, but don't worry. Majority can be a guess answer for this. Okay. Okay, let us stop the discussion now, and that is what I had to discuss with you all. Thank you. I hope we cleared most of your doubts, and session went well. And the take-home messages from this video discussion is whatever the possible questions for the future exams you are taking into consideration, and then move on. Okay. So all the very best for your future exams. Any doubt, I am there to take up. And another 2 minutes, and then we'll close the session. Thank you. And thank you all for giving your options. Thank you, Mr. Vikram. So already you are discussing about rank. That means very good. So don't worry, new question is new for all. For example, in a cricket match, if you become out to an easy ball, that means your mistake. Suppose in this question, if you don't answer the mechanism of action of INI-CET, that means your mistake. You have done that. Then you will miss a rank. But if you don't answer the use of pembrolizumab and endometrial cancer, that is fine. If you become out to a googly, that is fine, no problem. But in any exam, the repeated and easy question should never be made mistake. Each and every question counts for that. Yes, Satyam Prasad, we'll do that. Thank you. Take care. Anything you can comment in the YouTube section, and we'll be answering that. Thank you. Take care.